has certainly been the inspiration for me behind the whole charity. Many of you heard me introduce him before, but it was we hit it off fairly well from the off, I think, Mr. Rasheed, when you kept me waiting for about 3 hours for my first clinical appointment. And when I met him, I actually had a full lowdown on his background and everything he was involved in. He said, "How do you know all that?" And I said, "We've kept you waiting for so long. I had to do some research." So. And I think it's fair to say, Shanu, we've kind of moved from sort of clinician to patient to more of a friendship with a common cause, really. So Mr. Rasheed, or Shanoir, or Shanu as I know him, is a consultant surgeon at the Royal Marsden, probably one of the top specialists in the robotics in the surgery, in the theatre, a senior lecturer at London College, and a whole portfolio of activities behind him, including being the medical director of Humanity First. Shanu would like to welcome us and give us a bit of an update on some of his prime activities and why he loves what we're doing here. Over to you, Shanu.
Fantastic. Can I share my screen?
Yep. You should have abilities.
Yeah. Have I succeeded?
Yep.
You have?
Yep.
Okay, good. Well, thank you so much for everyone to join this evening, albeit by Zoom meeting rather than face to face. I mean, not only have we become friends, Paul, I feel I'm friends with all of you. You know, I feel part of you, and I feel that your contributions and your help and your support, it really has made all of it worth it, really, to a big degree, that we can all stand together and really support patients going through, you know, what is one of the most difficult times of their life. I know that Paul always tells me I talk too much, so I'm gonna rush through this thing as quickly as possible. So excuse me, but it is an absolute pleasure, honestly, seeing all of you there in the background and seeing your faces and your own homes. It's really touching, really touching. So I'm going to give you a bit of a whistle-stop tour of colorectal cancer, if I may. I know I'm scheduled to talk about bowel cancer surgery, particularly robots, but I'm gonna extend that a little bit. So excuse me for that, but I think it's important. You all know who I am now. The amazing introduction by Paul. I will show you my red trousers once more. Here we go. I've got my red trousers and my red tie on. Especially because I got back and got dressed, especially for the occasion. So bowel cancer is actually colorectal cancer. Bowel cancer is the word that we use more euphemistically, but it's actually colorectal cancer that we're talking about, because intestinal cancer almost always is within the colon and rectum. This is the 4th commonest cancer that we know of in the high-income countries, but it's one of the most treatable, and particularly because we know that cancers of the colon arise from a pre-malignant state, which is a polyp. And we also know that the earlier the diagnosis is made, the better the outcome every single time. And therefore we need to raise awareness within the community so that people are aware that their symptoms need to be investigated. The common, what we call red flag symptoms, a change of your bowel habit towards looseness, bleeding from your bum, tummy pain. Everyone gets tummy pain, but that can be a sign of it, although it's unusual to have tummy pain as a cause for it. Lump in your tummy, weight loss are the commonest ones. So any of those symptoms, please do get checked out, a colonoscopy, an assessment by a general practitioner, and then by someone like me. When I talk about bowel cancer, I always talk about this element of it, the connection that we have with our patients. And I think it's absolutely vital. And I'm not going to apologize for talking about this. It's not robotics. I'll come to that later on. But my approach to medicine has always been the same. It's vital that we engage somebody. You know, when we give, when I hear lots of doctors talk, and you all will recognize and acknowledge what I'm talking about, a lot of doctors and a lot of some nurses as well, they're not particularly good at communication. And the reason is they give their spiel to a patient in front of them, and they don't recognize that this guy in front of them is different from the last one. And actually every single person is different. They require a different approach. They require you to take that effort to engage with them, to build a rapport, and to demonstrate humanity ultimately, which is a combination of kindness and compassion. It's vital to listen to someone's views. I hear so many stories from so many patients, as you can imagine. Often when people come and see me, particularly with the advanced cancers, they might have seen 3 GPs and 4 specialists over the previous 2 to 3 years sometimes. And what they often tell me is, no one listened to me. I was telling them I had these symptoms and everyone just ignored me. And when I hear that, it makes my heart bleed. It really does, because the reality of it is that people will tell you why they come to the doctor if they haven't got symptoms. They're not going to make it up. Of course they're not. So actually, you just listen to people when they talk to you. A lot of people will tell me now, when I had the whole conversation with my GP, the whole time they were looking at their screen, they didn't even look at me. They didn't even examine me. They just had their view about things, the preconceived view about it. So listen to people, listen to what their concerns are, what their views are, take time to build trust, and then allay the fear that people will always have, both of the diagnostic pathway and also of the treatments. People are terrified of colonoscopies, examinations, scans, people who are a bit claustrophobic, and Paul will agree with this as well. The idea about going on an MRI scanner, often the medical profession will see it as this is the test you have to have done. But they don't consider the person actually arriving in the hospital, going up to the department, going into the scanner, having a line put in, and all the nitty gritty that surrounds it. So taking effort to actually talk people through that process and allay those fears is absolutely essential. I talked about these symptoms, but these are the red flag symptoms, and these are given to every single doctor in the country knows them. There's a process called the 2-week wait pathway, which means that anyone who has these symptoms requires a referral to a GP. So one of the elements of awareness, I think, which is important, and we touched on this in our conversation on Tuesday, Paul, is that we need to empower the public. The public need to know that when they arrive in their GP practice and they have got these symptoms and they are persistent, then they need to be persistent with the GP to say, oh, I'm really sorry, doc, but don't I fulfill the 2-week criteria for a referral to a specialist, doc? And it's shocking how many times I've heard the same story about people who go to the general practitioner 4 times, 5 times over a period of 6 months, 1 year, 2 years. And they get told, nah, you haven't got cancer, you haven't got cancer, you've got piles, you've got hemorrhoids, you've got fissure, you've got all the other things that they talk about. But the reality of it is, I can't look at somebody and say, you've got cancer or you haven't got cancer. But I know that if people have those symptoms, 100%, I would perform a colonoscopy on them and I would exclude a cancer, because that's what needs to be done. So it's important to, when we start to talk about awareness, it's awareness that people know that they fulfill the criteria for referral if they have these symptoms. That's one thing that I'd like the RTD gang to sort of pursue as a concept. I spend a lot of time lecturing GPs. I did one last week, and I stressed this point, and I think it's an important one to stress. I think empowerment of people is the way forward. People controlling their own healthcare is going to be the future. It has to be the future. It cannot be a paternalistic approach to healthcare. I don't think it works. I don't think it's right. And I think the autonomy of a person is key in all of this stuff. I'm sorry if you're having a dinner, but I'm going to show you a few pictures. This is what a polyp looks like. The normal colon is this guy here. These are the blood vessels. Those guys are just reflection of a little bit of liquid inside the colon. And this guy here is a polyp. This, I can look at it and say, you know what, this is benign, and I can remove it. And by removing it, you prevent it from turning into a cancer. What defines cancer is 2 things. And all of you who have come and seen me would have heard me say this. Those 2 things are the ability of that lesion to start invading into the lining of the wall of the bowel, and number 2, the ability of that guy to spread elsewhere. And they can commonly spread into the lymph nodes around the bowel, they can spread into the liver, the lungs, the bone and the brain, and anywhere else. And so that's what characterizes cancer. That's what defines cancer, the ability to invade and the ability to spread. If I see somebody like that, I can put my instruments through the colonoscope, which is a fiber optic telescope essentially, which can go around corners. And I can put an instrument inside along one of the channels. I can lift up the polyp, I can remove it, excise it, take it out. There is no cancer anymore in that patient. The risk of that cancer has gone. But I do need to survey that person's colon regularly and make sure no new polyps come and nothing abnormal arises. So on the left of my screen, I can see this is a normal colon. It's shiny, it's nice, it's got no badness in it. And on the right, this is what a cancer of the colon looks like. It's gnarled, it's horrid. And I can just tell by looking at it, that's cancerous. and it's gone around the circumference of the colon. You can see it all the way around, so it'll narrow the colon. Why do we get those two big symptoms, bleeding and a change of bowel habit towards bleeding? We get bleeding because this guy is unstable. The cancer doesn't like to be the cancer. It's not normal colon. And so it sloughs off at the surface and bits of it drop off, and that creates bleeding. Why does it create a change of the bowel habit? It's because two reasons. One, because when these are glandular cells within the lining of the wall of the bowel. And what that means is they secrete mucus all the time. But if they're disordered and abnormal, they create more mucus, and that creates a tendency towards diarrhea. And the second reason is as it narrows down, and it means the poo has to sort of liquefy. And again, excuse me for saying this while you're having dinner, but it liquefies in order to get through that narrow space. And that's why you get you get bleeding from the bum, and you get a change of bowel habit. And I think it's important. Again, I like to educate everyone on all this stuff, because it's important. If you go to first principles, it's not just I've got this symptom. Well, why have you got this symptom? What does that actually mean? And if people recognize that, then they'll be more inclined, I believe, in order to get those investigations and tests done.